The last video we talked about dead space, and here we'll go over shunt, which is the opposite type of VQ mismatch issue. This is principally an issue with ventilation. So we have this alveolus here that will not be ventilated well, but the flow to this is fine. So blood is going past and trying to participate in gas exchange, but there's just no ventilation here. So this is a low VQ mismatch situation. This is a problem because it causes hypoxemia. I'll show this on this drawing of alveoli and capillaries. We'll have the patient breathing room air, which is pretty close to 150 millimeters of mercury of O2. So I'll have O2 filling these alveoli, and this will be more than enough to saturate our blood to 100%. Now look at this side where our capillaries are not in contact with ventilated alveoli. So these ones are not ventilated because there's some kind of blockage of this airway. So this desaturated venous blood, which we can say has an oxygen saturation of about 75%, will pass by this place where it usually picks up oxygen, will remain deoxygenated. So no additional O2 is picked up, and then mixes with our 100% blood. So here it's still 75%. And then the mix of our blood here is something lower, so it might be 85. Depending on how much of this deoxygenated blood is mixing with our fully oxygenated blood that did participate in gas exchange with the ventilated alveoli. So that resulting low sat is from mixing with the shunt blood. Here, it doesn't matter if you try to breathe more, you can't get your blood any more saturated than 100%. So the issue is not that you're not breathing enough, it's that you have this blood that's being shunted through without picking up any oxygen and then mixing with your oxygenated blood. We already went over atelectasis a bit in another video, but anywhere that you have atelectasis, you'll have shunting because you are collapsing these alveoli, and for the most part, there will still be some perfusion to this group of alveoli, but they're not being ventilated. You'll see atelectasis with changes in positioning. So let's say this guy has a big belly that will press in on his diaphragm when he's supine and cause basilar atelectasis, collapsing the alveoli in this segment of the lung. So any of the blood going to this section of the lung will be poorly ventilated, therefore not oxygenated. So we'll see that mixing with all of our properly oxygenated blood, and the final oxygenation of this blood, I've drawn it as purple because it will be less oxygenated from this atelectasis from our positioning. You can see this kind of thing with a mucus plug or any obstructing mass. So let's block off this entire lobe of the lung. The mucus plug here will prevent ventilation of all of the tissue in the right middle lobe. So the blood going to the alveoli in our right middle lobe here will not pick up any oxygen, and our resulting oxygen saturation will be, again, lower. Same sort of thing happens with a pneumothorax. You'll have atelectasis or collapsing of the alveoli around where the lung is collapsed. And so in these regions that are collapsed, you may still have blood flow, and that means that it's not going to be picking up oxygen because it's poorly ventilated. So the contribution of blood from this collapsed area will be deoxygenated, and our resulting oxygen saturation will be lower. Last example here is with small airway collapse. Basically, if you were to get collapse of these small airways, you can't get any more gas in, Eventually, all of the gas that's in these alveoli will be absorbed, and then you'll end up with resulting atelectasis. The blood flowing through here will remain at its original venous saturation. Other common culprits for shunting are mainstem intubation and pulmonary edema. Mainstem intubation is relatively straightforward. If you're only ventilating, in this case, your left lung, maybe I should have drawn this tube going the other way because you're actually more likely to end up with a right mainstem intubation. In any case, this side will not be getting any ventilation whatsoever, so all the blood that enters this lung will leave at the same venous saturation that it started, and your resulting blood will be quite desaturated actually in this case. This, at least initially, is a very impressive size shunt because half of your blood flow will be going to your left lung and half will be going to the right lung. Luckily, this does settle down because these pulmonary vessels don't like to be in this relatively hypoxic environment, so they will vasoconstrict, or you'll get hypoxic pulmonary vasoconstriction. So eventually you will be sending less blood to this less ventilated lung, which allows you to successfully do one lung ventilation for thoracic cases. Pulmonary edema also causes low ventilation. Specifically here I've drawn alveolar pulmonary edema, but you can have pulmonary edema that is more so in the interstitial space as well, and that would impair diffusion. But here, since this alveolus is full of water or fluid, it cannot be properly ventilated. This type of alveolar pulmonary edema specifically would happen more so with aspiration, or could be the result of negative pressure pulmonary edema. Both of these things it's your duty to prevent in anesthesia. Negative pressure pulmonary edema will happen if you create negative pressure inside your airways or your alveoli against a closed airway. So if you're trying to breathe in against a closed airway, that will create negative pressure and draw fluid in, thus alveolar edema. And for aspiration, depending on how much you aspirate, you could actually end up in a situation more like a mucus plug where your large airways are blocked off by the particulate matter of what you aspirated, or a chemical reaction which would end up more like a pulmonary edema. Of course, you can get pulmonary edema from increased pulmonary venous pressure as well, which is essentially CHF.